Civil society has an unusually rich conceptual history and an uncommonly varied set of empirical reference. Indeed, the private sector and some international monitors, which are counted as separated actors in this course, are often viewed as part of civil society. Civil society can be defined as associations of citizens outside their families, friends, and businesses enter into voluntarily to advance their interests, ideas, and ideologies. The term does not include profit-making activities such as the private sector or governing the public sector. This seemingly straightforward definition obscures a considerable diversity of organizations, including labor unions, faith-based groups, professional associations, academic and research institutions, think tanks, human rights networks, consumer rights coalitions, social movements, social and sports clubs, philanthropic foundations, clubs, and indeed criminal organizations and networks. When we talk about civil society organizations, CSOs, we usually mean public interest CSOs that aim to benefit the public, whether as a whole or particular groups. Often, but not necessarily, vulnerable or marginalized communities. But private interest CSOs also exist that support the commercial interests of companies, such as lobbying governments on behalf of pharmaceutical corporations. Although it is not uncommon for them to hide their commercial agendas, thereby blurring boundaries between public and private. Civil society is a sphere of social life that is analytically distinct from the state and market spheres, even as it is closely interrelated with them. The parts of civil society that are most consistently important for diplomacy are the self-organized associations that engage in collective action that crosses state boundaries. Among these, the most prominent are the principled advocacy groups that mobilize in support of what they deem the wider public interest. Willis label for NGOs at the United Nations, the conscience of the world, is typical of this understanding of civil society. Scholars often emphasize the principal character of civil society in order to separate it from the for-profit sphere of the market sector. As will be discussed in more detail later, this set of civil society organizations are especially active in the normative and agenda-setting dimensions of global diplomacy and governance. Consequently, they can both enhance and diminish the broader legitimacy of global state-based action. While principal advocacy groups are important components of civil society, the definition used here is more expansive in two ways. First, it includes collective actors who participate in global politics on other bases, including the ability to provide expertise or services. The former are especially important on topics where expert knowledge is critical, including environment and health issues, while the latter are vital implementers of global commitments. Both also speak for the wider public interest, but tend to understand it in technical rather than normative terms, such as techniques of standardization or vaccination strategies. Concretely, this expansion means scientists, relief agencies, electoral observers, and the like are also part of civil society and important additions to the world of diplomats. Second, the focus on principal advocacy groups often smuggles in implicit normative commitments. With the label reserved for good groups, the term civil society itself implies an opposite of uncivil society, understood as groups pursuing unpalatable ends. In the Western academic literature, for example, research on civil society in diplomacy is heavily focused on a few topics that follow liberal Western norms, including human rights, gender equality, environmental protection, and democracy promotion. The literature is more divided on its assessment of organizations associated with the liberal economic order. Shifts in global health governance have brought opportunities and challenges. Substantial increases in development assistance for health, from $5 billion in 1990 to $21.8 billion in 2007, have occurred in parallel with a growth, some would say a proliferation, of global health actors. As Dodd explained in 2007, there are now well over 100 major international organizations involved in health, far more than in any other sector, and literally hundreds of channels for delivering health aid. New types of global health actors are emerging, and the importance of different actors is changing. Traditional actors, namely the bilateral donors and health-related multilaterals such as the World Health Organization, UNICEF, and the World Bank, remain important and influential in global health. New actors, such as philanthropic foundations and their civil society organizations, and global health initiatives and partnerships, are emerging as increasingly significant at the global level. Such actors have been welcomed for the new resources they can harness and the flexibility and creativity thinking they can bring to bear in tackling persistent and emerging global health problems, such as HIV/AIDS. However, they have also exaggerated existing and indeed introduced a number of new challenges to global health governance that we will look later in this lecture. Civil society organizations have been involved in a vast number of issues, such as gay rights, anti-poverty, anti-capitalism, canceling unfair debt, global warming, etc., etc. They are not limited on the healthcare system, but in broad sense of social care and issues. Civil society can play different roles in diplomacy. Research, outreach education, advocacy and non-promotion, agenda setting, lobbying governments and intergovernmental organizations to adopt and police laws, policies, and courses of action, implementing programs and delivering services and humanitarian assistance, monitoring implementation of international commitments, and direct action. Here, I will discuss the roles in more detail, presenting them in the order of policy process. Representing the voice of people. It means advocating for the needs of marginalized and vulnerable groups, conveying or amplifying their expressed opinions and experiences, and supporting local people to directly participate in global debates. advocacy and lobbying. Attempting to influence decisions through either confrontational means to challenge global institutions and their decisions, or consensual approaches involving participation and dialogue in shaping policy decisions. Research and policy analysis, through which generating and sharing data on, for example, impacts of global decisions and policies. Watchdog, that means independent monitoring and reporting on the policies and activities of global actors. Communication, sharing information and communicating global policy decisions to promote transparency that can be especially important where information is shared between actors in low and middle income countries, as well as those in high income countries. Involvement in horizontal governance mechanisms, working with and forming alliances with global health actors through formal decision-making mechanisms. Involvement in multi-level governance, that is participation together with national governments in global events and fora. Horizontal and vertical networking. Horizontal networking with other non-governmental organizations and vertical networking with government and multilateral agencies as ways to influence global health agendas. Building capacity of other civil society organizations, typically northern CSOs, supporting those in the south by providing resources, training, information, and contacts. Collaborating with global institutions in designing and implementing health interventions. Delivering health interventions as a way to reach poor, marginalized groups, excluded from mainstream services, and helping to inform government policy decisions about realities on the ground. What is clear is that CSOs are increasingly shifting their stance from outsider, targeting governments and other powerful health actors with advocacy campaigns, lobbying, and acting as critical watchdogs, to insiders, partnering with other global health actors as members of governance mechanisms and networks. Many CSOs are working with or are formally affiliated with UN agencies. For example, the WHO invites CSOs to input at technical networking groups and committees that it convenes at global, regional, and country levels. Civil society organizations increasingly influence global health through participation in global health partnerships and initiatives such as the Global Fund and the Gavi Alliance. Alongside governments, UN agencies, and corporations. Indeed, the participation is increasingly formalized through having vote seats on decision-making boards. Although some commentators suggest that this has increased corporations' influence on global health more than it has increased the influence of civil society on global health. There are several ways in which increasing across to funding may strengthen the ability of CSOs to influence health policies at national and global levels. Receiving donor funding may help them invest in management and financial systems, and this increasing professionalism can improve how governments and global actors perceive them. It can also enable them to travel to global meetings and conferences where they may have an influence on global level decisions and develop networks and alliances with other global actors. Increasing dependence on funding from bilateral donors and global health partnerships and initiatives, however, leads some commentators to accuse funders of co-opting CSOs, leading the latter to compromise their values and weaken ties with the communities and groups they claim to represent. This may also mute their voices as they shift away from more critical advocacy or watchdog roles towards service provision. Philanthropic foundations are a particular form of civil society organizations and can be defined as non-profit, non-governmental actors possessing a fund of their own, managed by trustees and directors, and promoting public welfare, including social, educational, charitable, religious, or other activities. However, it can be difficult to differentiate between foundations and other non-profit, non-governmental organizations, in part because the term is often used interchangeably with endowment, trust, or fund, and captures diverse types of actors that include private and public foundations, corporate foundations, single social entrepreneurs, venture philanthropists, and philanthro-capitalists. Among the advantages that foundations have over traditional bilateral and multilateral global health actors is their relative freedom to promote innovative approaches to health and other development issues. They are often able to draw attention to issues that are not emphasized by traditional actors and are freer than other actors to criticize governments and pressurize them to act. Large foundations are becoming important global health actors, much of their influence stemming from their substantial contributions to development assistance for health over the last decade. The Gates Foundation, with its large contribution to the WHO and the Global Fund, is widely credited with injecting energy into global health and increasing global attention on diseases such as malaria and polio. It is a key member of a number of global partnerships and networks, including Rollback Malaria and the Global Alliance for Improved Nutrition, and Gates funding of around 750 million US dollar helped establish the Gavi Alliance in year 2000. The foundation is even a member of H8, an elite group of global health actors that includes the World Bank and the health-related UN agencies, the Gavi Alliance and the Global Fund, and also a signatory of International Health Partnerships Global Compact in year 2007. Global health partnerships, a term often used interchangeably with global public-private partnerships, and sometimes global health initiatives, captures a range of financing, coordinating, and implementing entities that are diverse in their functions, size, and scope. Some focus on a specific health problem or disease, others on research and development of or donation of new drugs, vaccine, or other products, or working on broader health system issues, raising consciousness through campaigning and advocacy, technical assistance, or health service and system support. The urgent need to address persistent and newly emerging global health threats, such as HIV and AIDS, means that new thinking was required to harness the energy, business skills, innovative ideas and expertise, and financial resources of partnerships of traditional and new actors, including civil society and foundations, as well as businesses such as pharmaceutical corporation. Hence, many global health partnerships and initiatives were created in the late 1980s, 1990s, and the early year 2000s, and have become part of mainstream global discourse and a dominant model for cooperation in a complex world. Some of the largest and best-known global health partnerships and global health initiatives include the Global Fund to Fight AIDS, Tuberculosis and Malaria, the Gavi Alliance, and the President's Emergency Plan for AIDS Relief. These and others have mobilized substantial additional funding for health programs, such as funding equates to a considerable proportion of overall development aid for health in many low and middle-income countries. And in some cases, external funding from global health partnerships and global health initiatives for HIV/AIDS exceeds domestic budgets for health as a whole. This has led to a dramatic scaling up of HIV/AIDS program and has improved access to services for population with a limited ability to pay. These global health partnerships and global health initiatives are credited with raising the profile of particular health issues on national and international policy agendas, strengthening country policy processes and health delivery capacity, and establishing international norms and standards. They have also brought some consensus among different partners with diverse interests, although this consensus has been delicate. This has been broad agreement about the urgent need to mobilize substantial resources for programs to tackle HIV/AIDS, particularly in countries of East and Southern Africa. Well, do more actors mean better health governance? A few issues we need to look at. First of all, harmonization and alignment. With more and more CSOs, the problem is fragmentation, poor coordination among global health actors and implementers, and between external programs and recipient government policies, programs, systems, and targets. Such problems are fueled by competing priorities and mandates among donors and other global health actors, donor governments' national security, economic and foreign policy interest, competition for donor funding among implementers, and pressure to attribute outcomes to programmatic efforts while delivering results to ambitious timeframes. Poor harmonization and alignment have damaging effects on recipient countries with fragile health systems. Donors, including global health partnerships and global health initiatives, often introduce parallel monitoring or evaluation and financial management procedures and duplicate coordination mechanisms, adding to already complex governance arrangements that place a considerable burden on recipient country governments. The second issue is accountability and legitimacy. Unlike many national governments, CSOs are not democratically elected. They do not represent populations in the same ways as governments, and some commentators point to parallel between large loft CSO and colonial administrators and missionaries imposing ideas and values on sovereign governments. Indeed, while funding from donors and foundations may empower and enable CSOs to act at a global level, this may weaken links to the poor marginalized groups they claim to represent, and lines of accountability may be stronger to funders than communities. With increasing global funding being channeled through CSO health program implementers and thereby bypassing governments, the ability of the latter to build and maintain its own democratic legitimacy may be undermined. There have been calls for foundations to improve accountability and transparency, to focus investments on strengthening health systems rather than commodities and technologies, and to place more emphasis than they currently do on the most important global health issues. Last but not least, power and money, as well as far greater capacity and resources. The large CSO have far better access to and influence at the global level than the latter. Indeed, many smaller southern-based CSOs lack the capacity and resources to engage in global-level discussions, which often involve attending meetings in Geneva or Washington. The ability of large, well-funded northern CSOs to represent the views and needs of poor marginalized groups in the South has been questioned by some commentators who suggest they are more in tune with dominant ideas about globalizations and global health than potentially more critical ideas and perspectives of marginalized groups. Another concern relates to the potential for co-option of CSOs by bilateral donors and foundations, resulting in shifts away from advocacy or watchdog roles to implementing health programs. While this has professionalized some CSOs and enabled them to work alongside government and development partners, it may also mute the ability to challenge and hold governments and other powerful actors to account on controversial issues such as drug use, sex work, and HIV/AIDS.